Welcome to Treating TMJ, a journey to a pain-free life.
Not on the lower jaw. So we don't want the lower jaw getting bigger than the palate. That's what happens when the tongue doesn't go to the right place. So
in future podcasts, we're going to get into the physical therapy component of the treatment plan.
Yeah, that'd be awesome.
But that was kind of one of the many light bulb moments for me. I'm like, oh, okay, I'm on my back roller and doing my proper stuff and my neck stretches and things like that. And I'm like, okay, so now I actually used that in my own head. I said, oh, okay, I'm retraining my body to be in the right place.
And it's never, understand that, since you've been 5, your body's never been in the right place. Never. And your bite has never been in the right place because that's just the way it is. So until we can measure and create the right, and I'll just do it slow, 3-dimensional, intraoral means in the mouth, positioning with an orthotic, which is one on the lower jaw, which repositions the jaw appropriately. And then and here's the other thing people have to understand. If you have an orthotic that is designed by us, you can't just wear it at night. It won't work. Then this isn't the place.
You got to eat with it.
You've got to eat with it. Unless you function with it, you can't get better. And that's just the name of the game. I can't change that.
And but after you wear a while, you start to feel like, oh, wow, my teeth touch each other now. That's weird.
It's funny because your jaw does come forward, and then people go, if I take the orthotic out, well, then my teeth touch in a different way, and my back teeth don't touch. And that is exactly right. Everyone that gets well, I don't know if we should get into that at this point, but the orthotic provides the buttress, if you will, for the proper muscle relationship to the face, to the jaw, to your neck, and you have to keep that up. And at some point, we have to replace the orthotic. And that's what we talk about as well.
The measurements and the X-rays and the stuff that you do at this point in the journey, is it fair to call that your baseline?
It is absolutely. That is your baseline. That is your contingency for why the patient should be here. And for instance, when I put them on the neuromuscular computer and I attach the electrodes so we can read the muscle readings. Again, and everything in our office, I'm just going to backtrack. There's nothing in our office that creates pain. So putting you on a computer is only taking information from your muscles so we can read it.
Right.
So, but within the first 3 scans that we're looking at, I can absolutely prove you dysfunctional for as many years as you've been alive because muscle doesn't lie. And then there's another set of 6 or 7 scans that are showing the jaw dysfunction. And then we combine them, muscle and jaw, at the same time and read those scans. And that is a very powerful measure because that's the starting point of your function that you've never done.
And that's the cool thing about this appointment. When you're at this appointment, you're getting those measurements, and then you're going over with us. Here's what we're doing, and here's we're comparing this. Here's where you are. Here's where you need to be.
Yep.
And here's signs that this has been happening for a number of years.
Oh, yeah.
And things like
totally.
that. So the whole process, you do a great job of educating the patient on where they are and how they got there. Because then the next episode of the podcast is fixing that.
Yeah, and with dentists, if I'm doing in-houses, I tell them, well, you should work backwards because if they do a Panorex, and, well, I guess I shouldn't even go in there, but there's anatomy discrepancies that you can look at, not the TM joint. And a Panorex, it's not diagnostic for TMJ, the joint isn't, but the coronoid process, which is part of your jaw, you can use that, and you can use the angle of the jaw to understand what's going on with the bite. So you work backwards. So if you've got problem, if you can see that on a Panorex, you can also see that on a scan. So scans that when I ask people to clench on a scan or chew or bite or do things, I should see recruitment of muscles, and there should be a proportion of muscle recruitment. And when they're clenching and the densest muscle of your body, which is arguably your masseter, is clenching hard, but I'm getting no reading, that tells you something.
Right.
Because your body's in a lot of trouble because the accessory muscles are trying to offset what the masseter can't do, and that includes your throat muscles, your head muscles, and it's not unusual for people to suffer pressure behind the eyes and side of the head because that masseter is not working.
I always go back to that when I'm thinking about stuff is like, the moment the first time I heard you say your jaw works 5,000 times a day, and that's when you're not a loudmouth DJ like myself. Then you're like, and think of all the stuff that's around it. And then you're like, your ears, your eyes, your sinus, your brain, your neck, your shoulders, like everything's within like an inch to 4 inches from that spot.
You're absolutely right. And the cranial nerves, because the cranial nerves come from your brain through your face and and all the way down into the rest of your body. So they have to pass through the very stuff we're measuring. So it's God wouldn't have made the mandible to be the densest bone, or the masseter to be the densest muscle, or your teeth to be the densest structures if he didn't have kind of like a divine plan for it, because you're going to use it thousands and thousands times a day. So you have to function with it. Unfortunately, we're in, I see a lot of dysfunction because of the jaw's alignment. And there's a lot of questions about that jaw alignment business. But it's totally in families. You can walk this back. I walked it back to my family. It's the same thing. Even the great nephews have the same thing that their dads had, So I'm seeing it, and it doesn't escape.
Right. There's a lot going on in that spot in your body, and if that's chaos, more chaos ensues.
And that's why I tell people, my wait a minute, I'll get it right. Granddaughter. It's hard for me to say that. I'm used to being Uncle Paul. Okay, so this is my granddaughter, and my son called and said, "Dad, Eve is crying every night, and she's in pain, and we don't know what to do." And he said, "But I suspect it's TMJ." I said, "Well, Tim, yeah, there's TMJ in the family, of course." So I said, "Why don't you have Eve stand against the wall?" And they live in Walden, New York, so it's a little rough, but they did come. And he stood against the wall. I said, "Take a picture of her, and I want to see what shoulder's higher." And then Christy, that's the wife, she said, "Her shoulders aren't high. One shoulder isn't higher." I said, "Yeah, it is. Just take the picture and let me see it." And sure enough, I get the picture back, and Christy goes, "Oh, my God." And Eve's left shoulder was very high, and her chin was somewhat retreated. And now Eve's 10. I put her on the computer. We designed an orthodontic appliance. It's not fixed. It's removable, but you keep it in. And she was fine with it. She ate with it. She did everything with it. All the facial pain and stuff that she was experiencing went away. And now it's our job to make sure the teeth are in the right place.
Yeah, you actually hit on that. Nothing you do in your office is painful. It's like, no, the x-rays and getting hooked up to the measuring machines that are doing the measuring and things like that. None of that's painful. The biting your lip, the face pain, the head and shoulder pain, knee replacement surgery.
Thank you.
That stuff's painful.
Well, you definitely have the whole idea. Yeah, and that stuff is long term, and unfortunately, and we did talk about this a little bit, long term for all this stuff. And I did mention this before. I worked in nursing homes for 9 years, part time, Fridays and Saturdays. So I saw a lot in the state of Wisconsin. And basically, postural problems create wheelchairs because imbalances of vertigo, things like that, or because your head is forward, you don't have a sense of security when you walk, because that's a 40-pound bowling ball in front of your body. And so you don't have a lot of leeway if you slip. Slipping at age 20 and slipping at age 60 or 70 are two different animals.
Right.
So that's why a lot of those people were there, including swallowing, including respiration, things like this, and basically because they can't get out of a chair because of their neck and back problems.
And one of the great visuals you have about the airway, and I know some of the people in your office pick on you, is the toilet tissue tubes.
It sure costs a lot of money to get them, but here, can they looking? Okay, this is a normal toilet tissue tube. This is what your airway should look like, and that airway is right in front of your skull, so it's right here. And that toilet tissue tube has a hyoid bone suspended right in front of it, and that hyoid bone has 20 muscles that connect to it, to this jaw. So if your head is forward and if your jaw is dysfunctioning, those muscles tend to create problems. So this airway tube can become this airway tube. So it's
nearly a figure eight.
Yeah, it's kind of...
It goes from a circle to almost a figure eight.
Because everything starts collapsing. So this is the tongue, which retrudes the anterior part. And actually, it's the cervical or neck vertebrae collapsing inward because of the forward head that collapsed the back part. So if you've got this kind of stuff, you can't possibly expect to have a good airway, because when it just doesn't maintain its patency. So what we try to do, and what we do is with an orthotic, those muscles now become more balanced. And posture exercises, they can become more balanced. So we can get more of this kind of an airway, so that if a patient needs possibly a sleep appliance or whatever, we can make one optimally, measure it, and make sure that it passes muster with sleep tests, so that they can go about their business and and have really no problems. But the other thing is, we're not just blowing air through a tube. What we're doing is we're fixing the reason why the tube went from here to here, and that's the big deal. And that's where that forward head comes in.
And sleeping apparatus or a CPAP or whatever
That blows the air
just
through.
passes.
Which, hey, I have nothing against that. You need air. You without it, a lot of people wouldn't be around. But
It's a symptom thing, right?
Right. We're getting to the cause as to why you needed it. I think I might have gone over this. We had a patient that was on a CPAP for 6 years, and they came to my office because he feels like, sorry, but this is what he said, feel like crap. And he's been wearing the CPAP for 6 years. And he had terrible forward head, and you could see one shoulder's higher. And he was in his late 60s, early 70s. And we explained the program we do here. So can we change what's happening? We can if you're consistent or want to be changed. And through the course of time, took about 8 months, Marvin went to, I did talk about it here already, and he eventually started woodworking again and doing chores for his wife, which made her a lot happier, and he had energy again. So you can get the air, which I'm not against that at all. But the point is, the muscles are still not where they ought to be. The head hasn't changed. You haven't done anything to change that dynamic and the structure of the face dynamic with the jaw positioning.
And the changing of the muscle it takes time and repetition and
you got to be consistent, and that's the journey. And so I explain up front, it's a journey. You have to own it. You have to want to get rid of this. You can, but you have to be consistent with it. Muscle requires consistency, and muscle requires range of motion, but you can't get the right range of motion unless you know what it is and can measure for it. And that's why everything we do is measured.
So we've discovered we have the symptoms. We've gone in for our consultation,
exam. Mm-hmm.
And now we're all measured up. In the next episode, we're going to get our first orthotic, and we're going to head towards to head down the road to treatment.
And before we get to that, then the patient meets with one of my ladies, usually Mary, who will go over exactly what we talked about and exactly what the protocols are. So everything is spelled out. Codes are spelled out. Everything is spelled out, and it's the patient gets the copy, we get a copy. So there's never a mystery at our place because you know exactly where you're going.
And yeah, it's that's not necessarily how all medicine is done, right?
I guess, but that's how I do it.
Because here's what you're going to do, and what I like about you and how you go about this is you're kind of like, do you agree to do this with me? Because
Right.
if not, I've got other people.
Well, true, and I don't want to make you feel bad by you deciding halfway through that maybe you don't want to be consistent, but that wouldn't be a good thing. I don't want to create that. I want you to understand. So if you're going to do it, understand that let's do it together and let's work it together and let's get you feeling good. And that's what I'm all about. Because if you're hiring me, whatever you want to call it, I want to make you the best you can be. And that's what the office is about. So.
All right. Thank you. In the next episode, we're on our road to first phase of the treatment.
The next step up. Yep.
Perfect. Thanks,
Yeah.
Dr. Insolera.
Thank you. Appreciate it.